What's up?
What's up, DocP?
Not much.
How are you doing?
I am good. And yourself?
I'm doing good.
What's up?
Can't complain.
So, I guess hop into the festivities.
Yes, sir.
I
Yes,
guess
sir.
we'll give them a minute. I
Yeah,
guess
give them a
from
minute
here.
to trickle in, so we could give a little house rules today.
You the boss.
Hello, everyone. All right. So, thank you for all for joining. If you've been here before, welcome back. If you've never been here before, I'm Cola Red. We are joined by DocP, Dr. Johnson, Fibroid Slayer, Jitsu in Training. What else? You got so many titles. What else you go by? One of Pulse of Three. You got it all. But I was one of his patients. I shared my journey treating my fibroid disease on social media. Ever since I shared my journey, a lot of people have reached out with support, and a lot of people have reached out with their own questions that they wanted to ask my physician, some anonymously. So we've been doing this once a month to give people access to basically free game. And even if you're not local where you can't visit Dr. P yourself, this may equip you to be better to go visit your own physician. So I would like to ask tonight, if you want to submit a question, if you look at the bottom of the screen, there is a comment bubble with a question mark in it. Please put it in there instead of putting it directly on the screens, because we got a long list tonight. And that way, anything we don't get to, we can screenshot it at the end and we can roll it over to next month, because we're going to keep it going as long as people keep wanting it. Everybody understand? All right, well, let's start with question number 1. All right, so do different colors of menstrual blood mean anything? Should you be concerned if you are bright red versus dark brown, etc., etc.?
The short answer to that is yes. They do mean different things, and it's simply this. So bleeding. So when blood sits for any period of time, it pools, or if it pools, it coagulates, right? So anytime blood coagulates, it's going to be darker, right? So if I hear women talk about this all the time, like, I'm clotting, I've had clots, and freak out about clots. And clots really are not, it doesn't concern me or gynecologist unless you are having excessive clots. I don't care about the size of your clots or how, or I do care about if they come very frequently. But clots are just pooled blood. So if you sit for an extended period of time and that blood is kind of pooling into your uterus, it's hard to come out, right? So it'll come out when it can come out, and that's where the cramping is coming from. So the cramping comes from this blood is pooling, the clot is forming, the uterus is trying to push, and get the clot out, and then so it then finally pushes it out. And it really depends on how long the blood is sitting and how much blood accumulates for how big the clot is. But that's to say, with the different colors, when you're bleeding bright red, that means you're actively bleeding. It hasn't even had a chance to sit, right? So when you are exsanguinating and having, profuse bright red bleeding, that is a problem, right? No one should be having profuse bright red bleeding for extended periods of time. If you are changing more than a pad an hour, like, you really need to go see someone. Like, obviously during certain high points of when you have your period, maybe, the first or second day or what have you, you will have, very heavy, bleeding that comes out. But it should slow down. You shouldn't be, 7, 8, 9, 10 days in there and having bright red exsanguinating type blood, and just washing it, right? That is excessive. But as far as the different types of colors, that's really all that it means. If it's dark colored, that means it's been sitting, right? It's just pool blood or something that has been there for a while. And that could happen also too, like when you lay down. Like when you lay down, the blood is not just going to come out. Gravity is not helping it. It could just kind of sit in the uterus. And so then when you stand up into a supine position or to a standing position, now the blood can come out and it's going to be darker. That is normal. Don't freak out so much about the colors. Freak out more about the amounts. Don't freak out more about the clotting, because clots happen, but freak out about the size and the amount of clots. If you are just having big clots, big clots, big clots, big clots, and they're coming out, realize that that blood did start from somewhere. It's coming from your body. So if it's excessive, you can get anemic, you can get sick, it could be a problem.
All right. What in your blood work are they looking at to determine anemia? What decides if you need infusions versus if you need iron supplements?
So they're looking at the hemoglobin and hematocrit, like just quickly, right? I mean, that's the quick nut and bolts of it. They're looking for the hemoglobin hematocrit. So hemoglobin is specific. I mean, you could look at either one of them. When your hemoglobin is low, that will, lets you know that you're anemic. Blood is important because blood carries the oxygen to your different tissues. The less blood you have, the less oxygen you have getting to your tissues. That means your brain, your heart, your liver, your lungs, like, so important organs that really, really need oxygen. When you don't have blood in the system to carry that oxygen, you can get really, really sick from it. So that's why anemia can be a silent killer. Like, so you really need to address anemia. As far as dictating when you need iron versus when you need a blood transfusion, there are really no strict guidelines, right? What we know is like typically when you get below 7, right, that's when people typically start to get sick. Meaning shortness of breath, blurry vision, dizziness. Well, I was like, all right, well, I could be dizzy, I'll be okay. No, like if you're very anemic, right, and you get dizzy, or if you faint, or if you black out while you're driving, you can die. People could die. Or another scenario, you walking down the street, you get dizzy, you haven't eaten all day, you dehydrated, and then you're anemic, you fall out, you pass out, you hit your head on the concrete, and you get a subdural hematoma or some type of brain bleed. You can bleed out from that, right? So there are specific ways in which anemia can kill you. So that's why we don't let you walk around with very, very low blood pressure. I mean, low blood counts very often. Some people have chronic anemia, meaning that they've been anemic so long and they've been like sub 7, meaning like they've been in the 6s so long that their bodies have compensated. So they may not feel the symptoms. With that being said, it still needs to be addressed. So you kind of play it patient by patient. One patient that has like let's say a 6.8 hemoglobin may be totally different from another patient that just had a big bleed and has a 6.8 hemoglobin. Their bodies respond differently. So if I have a patient that's symptomatic that has like a 6-something hemoglobin, they may need a blood transfusion. Whereas a person that has had, chronic anemia and their body has compensated, first, you have to address the anemia or why she's having anemia, but she may be able to get by with the iron infusion or ferrous sulfate. But if that blood count gets really low, like below 5, I had patients that come in with hemoglobins of 3 or 4. That's not even a question. No matter who you are, you need a blood transfusion. Like, you could die like that. Not just from fainting or dizziness, but your blood, your tissues have a lack of oxygenation, and you can get really, really sick from that. Things start shutting down, dying. That's a problem. So those patients, so it comes a point where if it's too low, you definitely need a transfusion. But if you're in the range of like 6 and you don't have significant symptoms, it's an option for you to take iron or an iron infusion. Iron infusions just kind of work a little quicker, but a misconception is this: your body, right? It just because you take iron, it's not like your blood count goes up that quick, right? your body takes 3 months to make a new red blood cell. Like, so you're continuously having blood cells die, getting recycled, and then your body is making new blood cells. So if you're taking iron now, like the effects of that iron won't be seen for months down the road, right? So it's like, it's not a immediate fix. So if you are symptomatic, you're like, wow, I need a transfusion, I don't want a transfusion. That's because I can't give you iron and make your blood go up like that. If you're symptomatic, I need to have blood, give you actual blood, so that your blood count can go up, so that you don't get sick and don't have these problems.
All right.
That's a lot. These are kind of in-depth questions. They're pretty good. So
I know they got real deep on me this month. Yeah. All right. Is a menstrual cup better for you than tampons or maxi pads?
I wouldn't necessarily say better. It just really is about what you want and what what's good for you. For some women, you don't want to see no blood, or any blood rather, Also too, absolutely it could be a hindrance for sex, right? So going in, taking out a tampon, or taking, changing pads or whatever may be a hindrance to your sexual life. So they do have flexible cups that you could use and have sex with them. So you don't really have to worry about that. So for that, from a convenience standpoint, they're good. So it just really kind of just depends on your preference and what you want.
All right. This is a question from one of the male viewers. He says, FYI, men watch too. We also care about the women in our lives. As a male watching, I'm always so curious why women have so many questions about their hormones. What do they need them for?
Good question. No question. I mean, any women is like, what is he asking? Like we all, like, these are conversations we need to have. Like, you can't expect, men to be understanding if you don't want to have conversations with them. And the knowledge about women's bodies from a man perspective are completely ignorant. They don't know, so, and if you don't tell them, how do you expect them? The same way with sex. Like, we go off our own questions and talking to other men about it, and women don't want to have a conversation. How do you expect them to get good at it, right?
Exactly.
So having this open dialogue about women's bodies, what to expect, what's happening, or what have you, like, take your man to the doctor. Like, let him ask questions. Like, if your doctor has a problem with it, find another doctor. I have women that come with their man all the time. They got questions, and I want them to answer these questions, because it lets a lot of things, it takes a lot of the guesswork out of it, and it allows men to gain a level of sensitivity and understanding to women's bodies. But as far as hormones are concerned, it's just like this, right? So the major hormones that women have that we don't have are two. It's estrogen and progesterone. Those are produced by the ovaries. For women, they do a multitude of different things. Number one, first and foremost, the most important thing is it controls ovulation and pregnancy, right? So every month when a woman goes through her menstrual cycle, there is a fluctuation and a increase and a decrease of estrogen and progesterone, right? The increase of estrogen, this is very nuts and bolts. If I got any OBs, anybody in there, don't be like, oh, he needs money. Look, I am trying to teach the folks with this. I'm not trying to get into too much detail, so just follow me. Don't get all technical. So, but anyway, nuts and bolts. Ovaries are going to produce estrogen. The estrogen is going to build the lining of the uterus. Why is that important? That is in preparation to receive a fertilized egg. So every month, right after a woman has her period, it's a big surge of estrogen to build that lining back up. In the middle of the month, there's a pulse of a hormone that comes from the brain that causes the ovaries to produce a progesterone. That pulse will cause the ovary to release an egg, right? That egg is waiting for fertilization. In addition to that, the progesterone level is also going up. So the progesterone is like, if you think about like a building where you have bricks. So the bricks are like the estrogen that builds up. the mortar or the things that keep it together is built by the progesterone, which is also released by the ovaries, right? So the whole point of a menstrual cycle is to build up this lining, release the egg, keep a stable lining, wait for the egg to be fertilized by a sperm. Once that fertilization happens, it comes back through the fallopian tube and implants into this house that we just built on the inside lining of the uterus. It don't happen, whether birth control, whether sperm never hit home to this egg or whatever. If it don't happen, then that wall is coming tumbling down. That's your menstrual cycle. And that happens every single month. You don't implant into that wall, the hormones go down, and then that wall breaks down, and then a woman bleeds. That is their menstrual cycle. And it's going to happen every single month. That's what happens normally. Obviously, when you have other different problems or issues, that it doesn't happen that way. But that is the way the body is designed. With that being said, that's all the uterus is for. It is a house waiting to get pregnant. That's it. If it don't happen, it don't happen. Menstrual cycle comes down, and then you get build it up for the next month. With that being said, for men, understand that, you know, there are high levels of hormone that are happening every single month. And some months you're going to have hormone that's released, and this hormone is going to can cause some mood changes. Just imagine if you have to go through 6 or 7 days of just bleeding, of like you can't, you know, function. Sometimes you're having a lot of pain, like you got to rearrange schedules and work, you got to pick up kids, cook, work, do all of these things, and you bleeding and cramping and having consistent cramping, and you know, people want to argue with you at home, argue with you out in the streets. Like, you going through all of these things while these hormones and stuff are going up, and then somebody don't understand like why all these things are going on, that you may be a little bit moody, right? That's why, you know, you have to understand that there is a physiologic change that's going on in a woman's body that is not happening with ours, that can significantly affect them. And especially if a woman is having significant cramping or endometriosis or like significant pain, like there are things that happen and processes that happen that can impact mood and make women not act their normal selves, right? And with that being said, we all have obligations. One obligation is for men to be understanding and not judgmental. Another obligation is for a woman to understand that, like, if your mood is changing, you can sense it's changing, and there's a problem, you having pain, you having issues, to not continue to live with that, to make everybody else miserable. Like, actually see your gynecologist and start talking about these things so that, you know, you can have a happy home.
That was a good answer, and definitely help some of the guys that's checking in. So we got 2 questions that came through in the chat, and I'm assuming they're related to what you were talking about, so we're going to skip to those. What if the luteal phase is short? And I don't know how to pronounce that.
The luteal phase?
Yeah.
I just saw my daughter check in, so I gotta be easy. But but it's okay. So, you know, the luteal phase and luteal phase is the tail end part of the menstrual cycle, and it can be short, but just because it's short does not necessarily mean you're not ovulating, right? So that's the biggest point of the entire menstrual cycle. It's, are you ovulating appropriately, right? And if you're having menstrual cycles that are too frequent, meaning less than 21 days, or they're too long, more than 35 days apart, then you can have a very long luteal phase or extremely short luteal phase, and that will impede ovulation. That's what we worry about. Not so much concerned about, oh, I got a 25-day cycle, I got a 26-day cycle, versus, oh, I got a 34-day cycle, or what have you. Both of those 2 things can be true, and both of those 2 things can still have success when it comes to pregnancy and when it comes to like just a normal regular cycle for a woman. So luteal phase shortening can be an impediment for fertility, but if everything else is normal, it's not anything that you necessarily need to worry about or focus on.
All right. And another question that came through that was related to the topic we currently on. After a hysterectomy, what happens to the estrogen and progesterone?
Great question. Phenomenal question. I want everybody to pay attention to this, right? This is such a misconception, okay? Women, no, I ain't getting no hysterectomy. I'm getting a partial or a complete or this or that. Like, listen to me, people, okay? Your uterus and your ovaries are different. They are different, okay? Just because you have a hysterectomy does not mean you touch the ovaries. You don't necessarily have to touch the ovaries. Just because you have a hysterectomy does not mean you're going into menopause either, right? You can have a hysterectomy and keep the ovaries and preserve your ovarian function. Your ovaries produce hormones, your uterus bleeds and gets ready for a fertilized egg and holds the pregnancy. They are two totally different organs, right? I talk about this all the time as far as terminology, right? I hate like complete partial hysterectomy, it's not right, okay? And then I'm gonna have this conversation again. Hysterectomy, hyster, meaning uterus, meaning ectomy, right? Anytime you hear ectomy, cystectomy, cholecystectomy, hysterectomy, anytime you hear the word ectomy on anything, it means the removal. So hyster, uterus, ectomy, removal, right? Hysterectomy means remove the uterus. There's no partial, there's any of that stuff. Like people started to use complete and partial hysterectomy to mean taking out the ovaries, right? If you had a complete, that means you took out the uterus and the ovaries. That's wrong. If you had a partial, that means you just took out the uterus. That's wrong, right? Hysterectomy means removal of the uterus, period. Now, subtotal versus total hysterectomy is the terminology we use. So in a subtotal hysterectomy, that means you just take out the uterus, you leave the cervix. In a total hysterectomy, means you take out the uterus and the cervix. Why is that important? It really is not, right? People are worried about their cervix, can't have sex right, like can't orgasm right, can't do all of these things right. It's not true, right? You do not need your cervix. If you're getting a hysterectomy, take the cervix out. The only time I leave a cervix for a hysterectomy is if I'm doing a suspension procedure or if somebody has prolapse, right? That's a whole other conversation. But if you have fibroids, you have bleeding, you need a hysterectomy, take out the uterus with the cervix. That is a hysterectomy. Now, when it comes to ovaries, right? Do you remove the ovaries when you do a hysterectomy? Yes or no? That's different, right? The ovaries, remember I said they produce hormones. They produce estrogen, they produce progesterone. For women, it's not just for having babies to produce those hormones. It's also extremely important for your heart health and your bone health, right? Studies will show that women get their ovaries removed early or very early, they don't get some type of replacement or what have you, can decrease their life expectancy because there's an increased risk of osteoporosis, increased risk of heart disease when you remove ovaries early. So my advice to all my patients, if you are young, the younger you are, the more likely, the more benefit you have for keeping your ovaries. However, if you are menopausal or very close to menopause, there's not so much a benefit, but the risk of keeping your ovaries is still kind of elevated, right? So you have a 1 in 9 chance of getting ovarian cancer at some point in time in your lifetime. That risk elevates as you get older. So if it's my mama, my auntie, right, somebody in my family, and I'm telling, they're up for a hysterectomy and they're in their 50s or late 40s, my advice would be to take the ovaries because I don't want her to be 70, 75 with a cyst on her ovary, having to worry about if it's a cancer or not, right? But if she's 45, 44, 43 years old, like you were, like we had the same conversation, right? Keep it.
Are you telling my age?
I'm sorry. No, I said I gave a range. You saw me give a range. So if you're younger, obviously you keep your ovaries because they are important. The benefit of keeping your ovaries with the estrogen, progesterone production is important for your heart health, bone health. So I hope I answered that.
Yeah. No, that's what they wanted to know. All right. How long on average is an abdominal myomectomy procedure, and what is the average recovery time?
Great question. I really can't tell you the average of those because it really is how extensive the fibroids are. I just did an abdominal myomectomy today, and it was probably in the neighborhood of 2 hours, close to 2 hours, right? But I removed probably 25, 30 fibroids, right? So the more fibroids you have, or the more complicated it is, the longer it's going to take. As far as, and also people have previous, you know, if you had a C-section in the past, you have previous surgeries, you have other complications, you know, it just really kind of depends on the person and the patient, and as far as how long surgery takes. But typically about 2 hours conservatively, right, to do it right. Recovery is important, right, and that's different. And I don't like to my own horn, but again, I do it different. I make the incision as small as I possibly can, and I put everything back the way it is supposed to be, and I don't do excessive cutting. So for me, my abdominal myomectomies, they either leave the hospital the next day or they leave in 2 days. I've heard a multitude of patients where they leaving out of the hospital sometimes 3, sometimes 4 days, right? It's how you keep that incision. If you keep that incision small, keep it very low, I found in my experience that patients tolerate that much better and pain is much less. Pain is what keeps you in the hospital. If your pain is controlled, you get to go home. If your pain is not controlled, you got to stay. Also, it depends on the type of incision. So abdominal myomectomies can be cut up and down, or they can be cut horizontal. I never cut up and down, but I know many patients, I know many doctors that will still cut you up and down. If you get cut up and down for a myomectomy, you will be in the hospital no less than 3 days. You're going to be there 3 to 4 days. Recovery time is 6 to 8 weeks. That's why I am a big proponent for not doing that. Like everybody should have an opportunity to have a, you know, horizontal incision and as small as possible for their myomectomy. So, you know, I wish I could tell you a specific time. Typically, they will tell you 6 to 8 weeks. My patients don't experience 6 to 8 weeks. You know, they'll, like my patient today, like she'll be back to work within 2 weeks, right? So yeah, it's just how you do it, and it makes a big difference.
All right, for those of y'all just joining, if you have a question, please use the comment box at the bottom of the screen. It's a bubble with a question mark in it. I'm going back and forth between the ones that were submitted prior to the live and the ones that are being put in that question box. So those of you who are joining, please use the question box at the bottom of the screen with the question mark in it. So I'm going back to one on the screen. Do you perform pelvic floor reconstruction surgeries?
Yes, I do. So if you want to
right.
explain that, but yes, I do perform pelvic floor reconstruction surgery. I kind of explained that a little bit, but yes, I do.
All right, this question is actually for me. Cola, how much was your surgery? So I'm assuming they mean how much did I have to pay out of pocket, because that's the only part that really impacts me. So I have employer provided insurance, and I have a PPO. So my insurance has an annual out of pocket that they decide you can't pay more than every year. And I don't use a lot of my out of pocket because I just really get physicals, and overall I was a healthy person. So my surgery out of pocket was $1,727 or 25. It was 20 something. You do not have to pay it up front. The hospital called me before my surgery and guesstimated how much I would have to pay and asked me did I want to pay a payment up front. And then once it was over with, they called me back and said, okay, now we know for sure what you're going to have to pay. Do you want to get on a payment plan? Do you want to pay it all at one time? Do you want, however you want to do it. So you don't have to wait to get surgery till you have $1,700 in your pocket. the hospital is more than willing to work with you to get your procedure done and get you some relief for what you're dealing with.
And I will tell y'all right now, it is not me or gynecologists getting paid from it. Like, everybody makes more money off of me doing a surgery than me.
I can definitely
my cost
to that.
My cost for that, like, anesthesiologists get paid more than me.
They
Hospital definitely get paid more than me. Everybody gets. I do not do surgery for the money. There are a multitude of other different things that I do for money that are way more lucrative than surgery. I literally do this because I care about folks and I want to see people do well. I want to heal people. But this is, trust me, this ain't that. Like, I kick myself every day and be like, why the hell are you doing this? And you could be doing so much other stuff for money. It is not that. It is I could do liposuction. I can go suck the fat out of somebody right now and spend 3 hours. I could make way more money doing liposuction than removing a large organ out of their body. Facts. I can go, and when y'all see me post and like teaching, and I'm teaching all of these surgeries over there, I get paid way more money to teach somebody a surgery than actually doing the damn surgery. Swear to God, real facts. But I continue. I'm a glutton for this because I really like seeing people like Cola Red. Like, this is like my passion to do it. So I never want to hear people be like, oh, da, 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 da. Or when they do like consults and stuff with me, oh, you're making up. Like, it's not that. Like, I swear to God, it's not that. This is not a very lucrative thing for me. I do a lot of other different things that do better for me. This is strictly because I have a passion to do it. So don't think just like, oh man, these hospital costs, blah, blah, blah. It's everything else but the actual doctor that's doing the surgery. Please believe.
You see somebody at the door. Did you get it? Oh. Sorry.
Dog said, I need a treat. Something. Shit. You want me to be quiet? What's going on? Give me a sausage or something.
So mad. I think she know I'm on live, so she like, you're not.
Yeah, she like, look, man, I need some attention. Fuck.
All right, let's move it right along. Does hormonal birth control shut off natural production of your hormones?
Does it set it off?
Shut it off.
Shut it off. Yes, absolutely. So the point of hormonal suppressants or birth control is to basically trick your body, right? Or trick your brain into believing your ovaries are doing something when they really are not, right? So when you see birth control pills are pretty much 1,000 different birth control pills, but they all do the exact same thing. They do the exact same thing. They have different levels of estrogen, progesterone, and and that's for particular different reasons, because you have some women that need more estrogen, some women need more progesterone, some women need less estrogen. That's why so many different concentrations. But the premise of the birth control pill, or anything with estrogen, progesterone, or progestin, is to tell your brain that your ovaries are producing these high levels of hormones, so that your brain doesn't send these signals down and your ovaries stop producing the actual hormones. That's what birth control, hormonal suppressants, that's what they're doing. They are literally tricking your brain and making your ovary produce a lot less hormones. That's it.
All right. I'm going to go back to a question submitted in the on the screen. Have you ever performed a wait, let's spell it. So it starts with Hyster, OOSALPING
Have I ever performed a hysterosalpingogram?
There you go.
I don't perform them. I order them. The reason why I don't perform them, because I don't have the tools. So a hysterosalpingogram is when radiologists basically take a scan. So they shoot a fluorescent dye into the cervix through the uterus, and what they're looking for at the scan to see the outline of the uterus, of the inside cavity of the uterus, and to see if that dye is actually spilling out into the fallopian tubes and into the pelvis. So that's one thing that we look for as far as like infertility and stuff is concerned, is we're looking for the pathway. We're making sure that there's a clear pathway from your vagina to your cervix to your uterus through your fallopian tubes into your belly. If you do not have that pathway, that means nothing can go in and nothing can come back through, right? That is infertility, right? So eggs are released inside of the body and they're swept back through the fallopian tube where they wait on sperm to come in and they get swept all the way back to the uterus. If you don't have that, if there's a pathway problem, that union and that sweeping back and fertilization will never happen.
All right. Can large fibroids and large uterus cause organ damage?
Damage? It rarely, but yes, it can. And one way it could do that, and I had a patient like this, actually, well, yeah, I had a patient where your fibroid, and again, you have to have a large fibroid. I have patients that come in like they had with 4 or 5 centimeter fibroids, and the doctor or somebody that told them they did something has done nothing. That's a lie, right? Nothing less than 10 centimeters is really significant when it comes to like pushing on things. Even 10 centimeters is not big enough really to cause this problem. But a fibroid can push on your ureter, which is the tube that goes from your kidney to your bladder. If it pushes on that, it can impinge on one of your ureters and cause urine to not be able to pass through your bladder and start to push back up to your kidneys. That can cause a kidney failure. It's usually acute or temporary, but it can cause your kidney to shut down if you can't pee and your pee is going back up the other way. Yes, it can. You know, or if your bowel, if your hold on a second. Yes.
Hi, Dr. Johnson.
Hello.
All right. If you
What's
are
up?
just joining, please
Cheers.
make
All
sure
right.
that
Don't
you use
let
the
her
question
push
box at the bottom of the
I
screen
said don't let her
to
push it.
submit your questions.
No.
We only have the good doctor for about
Just
an
wait.
hour, so if you
In
put it in
about
that question box,
10
we're
minutes.
able to screenshot before
All
the
right.
end of the
Thanks.
live so we can
All right.
make sure that we continue your questions for the next month. So if you're just joining, please use the question box at the bottom of the screen. There's a comment bubble with a question mark in it. Use that to drop your comments. All right. Sorry, Doc.
All right. So back, what was the name? I just got.
We were talking about a large fibroid or a large uterine
Oh yeah, pushing
damaging
on it.
your
So
organ.
if a fibroid is like large enough to where it's pushing on your bowel to where your bowel is being constricted and you get like chronic constipation, it could cause a problem. I may have seen that once or twice. Like we're talking extremely large fibroids that would do this. You don't really have you don't have a lot of fibroids that would do that. He's about to deliver, baby. Don't let her push. Yeah, she'll be all right. She's fine.
All right. Does hormonal birth control accelerate fibroid growth?
No, it doesn't. And this has been studied a lot, like multiple studies. But yeah, birth control does not accelerate fibroid growth. Birth control is synthetic versions of what your body already produces, right? So your body already produces estrogen, progesterone. Birth control, the hormonal suppressants are synthetic versions of what your body already produces. So it is true that fibroids are fed by hormones, estrogen, progesterone, but they don't accelerate it, right? So as women with fibroids, you're not removing their ovaries, they are producing estrogen, progesterone, they may not grow. But other women can have fibroids and they grow extensively. We don't know why that happens, why some women can have 15 centimeter fibroids and some women can have no fibroids and some women can have 3 centimeter fibroids that stay that way for 10, 15 years. We don't know, right? In answer to that. But we know that taking birth control does not accelerate that or make that extremely large or whatever. If it's going to happen, it's going to happen.
All right. In PCOS, does the cyst on your ovaries go away without surgery?
So those cysts or polycystic ovaries are just follicles. Those are not like true cysts per se. You know, it's not, that's not the problem. The problem is an abnormal level of hormone level, which is typically excess insulin in the body. And that excess insulin can cause the other hormones in the body to be excessive, i.e., male factor hormone, right? Which is why women will have, you know, male type growth of hair. So it can cause everything else to be out of whack. It's not the cyst or the follicles on the ovaries that are the problem, and they're small. They're extremely small.
All right, this is another submitted question. If you have the COVID vaccine and you are eligible for a booster shot, should your booster be the same that you previously took, or should you try a different version for the booster shot?
Ideally, it should be the same. I mean, that's really because we just don't have a ton of studies with crossing. But, you know, the studies that we do have actually do show that there is better coverage when you do that. But we just don't have enough study to make that definitive statement. So until we do, you know, with all of these conspiracy theories and all these people is talking crazy, it makes more sense to do it with the same thing. Like I have Pfizer, I had, you know, I had 3 shots. My booster was a Pfizer too. But if they didn't have Pfizer available and Moderna was available, I would have taken a Moderna. Like I would have personally done that. So there's no harm in it, but we still need more data as far as like if it's, you know, which one is better to be able to, you know, if you take another one or not.
All right, this one is a sexual health question. Is it true that a man's G-spot is in his anus?
No. 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 It's not a G-spot in the anus. No. Absolutely not. Okay, so let's talk about that. All right. So what they're referring to is prostate-induced ejaculation, right? So if you, and I have no idea, I know physiologically, I know anatomy-wise, never in my life.
You just know
don't
anatomy.
There's, you know, pause before y'all be like, oh, how you know somebody? Look here, I don't play no objects, fingers. I don't know nothing about my ass. Like just no, absolutely not. But anyway, I gotta be cool because my child is on here somewhere. But anyway, so your prostate is the gland that it kind of basically like provides like the sugar for the semen. It kind of makes like the viscous part of semen, right? That sits, I said I'm so weak right now. That sits right at the top of the urethra, right? If you, and that's where you check prostate exams through the anus. So if you go through the anus and you like put your finger not toward the back, but the finger up towards the front, right? If you push it all the way up and towards the front and hook it, that bulb, that little ball right there is the prostate. If you milk that and rub that, you will cause a man to ejaculate, right? So that's why homosexual men, that's where they get their pleasure from the prostate. Now, with that being said, just like women, you know, men can orgasm any type of way, you know, multiple different ways. Y'all can orgasm with clitoris and all type of stuff. That does not mean that's a G-spot. That just means that's another different way to get there. If you like that, God bless you, do what you do. But for heterosexual men, you have your quote unquote, your analogous G-spot would be at the glands of the penis, right? Because the analog or the similar structure for a man to a woman is the clitoris, which would be for the man the glands of the penis. So stimulating the glands of the penis is similar to stimulating clitoris, which is actually the G-spot of a woman is on the top part of the vagina, approximately like 2 to 3 centimeters in. And that's just an extension of the clitoris, which is along the urethral wall. So that's the G-spot. And for a man, it would be the glands of the penis. Somebody said not homosexual man. I was just I'm trying to be politically correct. Y'all stop me if I'm not. I'm just letting everybody understand.
That was a question. So that was an anonymous submission. All right, this is another sexual health question. In a previous video, you mentioned do not insert anything into your vagina. What about sex toys? Ice cubes. Are there specific materials in sex toys that you should avoid?
No, as long as they're clean, right? You can use sex toys, but they have to be clean. Just remember that when you implement bacteria into the vagina, that's where infection starts, right? I just had a patient that came in this week that just couldn't understand whatever, but she was like, I don't have sex with men. She has sex with women, but they share toys and they share things, right? So if you're not cleaning those toys and making sure those toys are damn near sterile before you insert them in your vagina, it's the same thing as putting a penis in there. You're just inserting bacterium into the vagina, which can cause infection. But I'm not saying don't put things. I'm not saying you can't use fingers, objects, or what have you. They just have to be very clean, i.e. wash your hands extensively before they go into places.
All right. Do you perform tubal ligation reversal?
No, I don't. Can I? Yes, but I don't. Reason being, number one, it is an extremely low yield procedure, right? Number two, low yield meaning that it's not very successful. So tubal reversal surgeries have about a 10 to 15% success rate, which is not very high at all. There's also an increased risk in ectopic pregnancies with tubal reversal surgeries, meaning that the newly formed fertilized egg can get stuck in that tube. If you go to a fertility doctor and you're looking for that, they would most of them will not do it or will not really go through a cycle with you if that's what you're seeking or that's what you want. Reason being is because fertility doctors, they get paid by the success rates. If they're not successful, their dollars go down. So they don't do a lot. So that's why they look for BMIs at 30 or less, no pathway issues. Like they want to optimize everything. So they would much rather do in vitro fertilization than try to go through this entire cycle with a tube that may be compromised. So I don't particularly, I won't say that I don't agree with it, but it's just not high yield. Somebody get an ectopic pregnancy, somebody have a problem. It's like, why'd you do the tubal reversal? So I don't necessarily do it. It can be done, but not when I do tubals. When I do tubals, I don't do tubals, like for real. Like I take tubes off. Like, so you won't have the opportunity of reversing. Like if you get sterilized with me, I'm undefeated. And you never had nobody get pregnant after I do them. That's because the tube is coming all the way off. It's not no burn, a cut, a clamp, a clip, none of that stuff. All the way off tube. And that's what more and more doctors are moving to now, because what we found is that a lot of ovarian cancers actually originate in the fallopian tubes. So if you're going to do a tubal, or if you're going to remove ovaries, or you're going to do even if you do a hysterectomy, you remove the tubes. Even if you're keeping the ovaries, you remove the tubes as well.
All right. With an open myomectomy, if there is excessive bleeding, does a hysterectomy have to be done?
It doesn't have to be, but that is a risk of surgery, right? So a risk of surgery is that if there is excessive bleeding and it can't be controlled, then it's a possibility that you may have to have a hysterectomy. In the hands of a skilled surgeon, you should not have that happen. I've never had to do that for that reason. The only one time that I could think of that I've ever had to do that is when I had a patient that unfortunately had a cancer. And it was much, much worse than what we ever thought when I went in there and did it. So I had to remove her uterus. That is the only case that I can remember in the past decade of me working that I can remember having to do a hysterectomy when I'm planning for a myomectomy. However, I know multitude of patients and multitude of doctors that have done it. So, if you are worried about that, you really need to do your research on your doctor and really have that trust that the only reason your doctor will remove your uterus is to save your life, not just because, things get a little difficult. They need to, make sure that they know that you want to keep your uterus, and they're going to do everything possible to not perform a hysterectomy.
All right. What are your thoughts on probiotics for vaginal microbiome?
Y'all not gonna like this answer, but it is another one of those things where you just donate your money. Like, if I can just tell you, oh, I got this nice thing or whatever, such and such, like, I'm gonna sell it to you and I'm gonna take your money from it, right? So the thought process is this, right? This is the thought process behind it. So the vagina has bacterium that are normally there called lactobacillus, right? When those bacterium get low, then bad bacterium can overcome, right? So probiotics are basically giving you more of those bacteria. It's literally bacteria. You're drinking or eating bacteria that they have in there to increase the bacteria in your vagina. This is the problem. Probiotics for the gut makes sense because when you eat, you swallow, goes down your esophagus, goes through your stomach, and it travels through your gut, right? Probiotics for vaginal health don't make sense because when I eat, it goes down my esophagus, it goes through my bowel, or goes through my stomach, goes through my bowel, goes out my anus, and goes out. Guess what? It's not going to your vagina, right? So eating all these probiotics and taking these pills, what have you, to increase the vaginal flora of your vagina doesn't really make sense. And it's been shown, studies have shown that you don't really increase the lactobacillus or the vaginal flora by taking probiotics or taking these different, pills and stuff or whatever. But again, I could sell it to you and you can take it. It's like, V-steams. I could do all types of stuff. I could put all types of herbs and everything, tell you it's making everything floral. Just give me all your money. Don't give it to me because I haven't. But I'm telling y'all, at a certain point, I'm gonna throw away all of this stuff and be like, look, like I need to be a millionaire. I'm gonna come out, smack my name on something. Y'all want to buy something? Here you go. Boom. Magical elixir. Doc Johnson. Boom. I'm out. Y'all can talk about me if you want to. I'm gonna be on the boat.
All right. My friend recently had a myomectomy. During her follow-up appointment, she advised her physician that she had leg pain and swelling. An ultrasound detected a blood clot in her leg. Is this normal after that procedure?
It's not normal after any procedure, but can it happen? Absolutely, right? So blood clots or clotting of the blood can happen, and you have even a higher incidence after surgery. Why is that? Because you're in a sedentary or stationary position for longer periods of time, right? So when you have surgery, you're not able to get up, move around. You're sitting, you're laying down, whatever. So, the more that you do that, the higher the incidence your blood has to clot, and those clots can be deadly, right? So it's not normal per se. People have higher risk of clotting. And for those higher risk people that have clotting, like we give them anticoagulants preemptively. But you can it's not normal per se, but it can happen. You just have to, really just kind of do a very good assessment of a person's history, and be very cautious. Like after surgery, you should have compression devices on your legs to help move the blood while you're not getting up. You should be getting up, moving around. And if you have things like hypertension, obesity, family history of blood clots, those types of things, like anticoagulants or anti-blood clotting medication should be given to you post-operatively to help decrease the incidence of blood clots.
For women over 40, what options do they have for birth control?
So this is kind of like a risky, kind of a topic that is taboo. Let me see. Let me make sure that I'm gonna have to go. We'll see.
Yep.
Hello. Okay, here I come. All right. So yeah, we're gonna have to cut it here. It's an hour anyway.
That's okay.
So,
we at the hour anyway. So as always, thank you. We will do one in April. Continue to submit your questions. I've already been screenshotting because I saw the time clock going. So if you did not get your question answered today and you put it in the question box, I got it. So thanks, Doc. We appreciate you.
no problem. So we'll do it again next month.
Yep.
All right,
I got
everybody.
you. Thank you.
I'm gonna post this one. So if y'all want to see any of this stuff, you can ask more questions. Don't send them to me. Send them to Cola.
Send them to
I already got enough stuff to deal with.
And I'm
So
gonna put it on YouTube as well. Yep.
All right, Mama. I'll talk to y'all later.
All right. Take it easy. Bye-bye.